Dr. I'm Dr. Olasukanmi Fatai Salau. I'm a general medical practitioner, Witham, the Douglas Grove Surgery, Witham, Essex here. My background is general medicine. I did all the way to the senior registrar level before venturing into general practice. So with my background in general medicines, so I have quite in-depth knowledge of what happens in the community and at the hospital level. And I've been a GP now for going almost 20 years, considerable level of experience. So please, I'll try and make these interactions very, very simple, and so that we have what's important, knowing what's important. So please, thank you. Can we start, Annie? Hello? Yeah, okay. Brilliant, thank you. Right, the topic of the day is hypertension and diabetes. We've brought these two important illness together, to appreciate, because it affects the over 50, the Black people mainly. Majority of Black people suffer from diabetes and hypertension. So the topic is quite close related. If you want to stop me at any point in time for very key important things, please feel free to do so. It's nice to be interactive. So hypertension and diabetes are a very strong marker of cardiovascular illnesses. Cardiovascular diseases involve things like heart attack, stroke majorly, and the precursor, the main determinant of people having a cardiovascular event is having an uncontrolled hypertension or poorly controlled diabetes. So it's very important to have a diagnosis of these illnesses, to know what it's all about. Can we go to the next slide, please, Eddie? Now, hypertension, to simplify it, and diabetes, they are silent killers. The simple name for hypertension is high blood pressure. So when we talk about high blood pressure, we are talking of systolic blood pressure reading of more than 140, the top part, so which we could measure ourselves at home. So the usual marker is 140/90 or less. If your blood pressure is below 140.
I just did for one Zoom meeting like that.
Okay, sorry. Yeah, if your blood pressure is 140/90 or less, you're not hypertensive. But if it's above 140/90, then we classify it as being hypertension. Then we talk about what we need to do. So hypertension is usually diagnosed between the age of 18 and 80 years old. Although you could have some children with hypertension, but that does not affect this group. So I wouldn't really go into that. So anyone above the age of 18 to 80 with that blood pressure reading more than 140/90 persistently, you do not need one reading. You need a series of readings. Then you diagnose them as being hypertension. Next slide, please. Now, we talk about all these steps to arrive at diagnosis. The good thing, technology, people have Fitbits on their wrist. You could have your blood pressure monitored. You could buy the Sphig, from the pharmacies and check your blood pressure in the morning. You could do that yourself at home. And if it's more than 140/90, like I said, you need about 3 readings, consecutive readings. So if you do one this week, try and do another one the following week or 2 weeks later. You need about 3 readings. That's one way of that. And if the average is more than 140/90, you need to speak to your doctor. That we use the word home monitoring of your blood pressure yourself. When you do that, your doctors might decide, okay, let me try and put you on what we call ambulatory blood pressure monitoring. This is when they give you a kind of device, you put that they kind of fit it to your hand, and then you measure your blood pressure over a 24-hour period. And the average is how they arrive at whether you are hypertensive or not. So we have to be very, very careful not to rush into diagnosing high blood pressure. It needs to be carefully done. The only time that you need to be very, very careful, it's when your blood pressure is markedly high. The systolic of like 200, the top part. We're talking of something above 140. Let's say you're about 145, 150, 160. There's no rush to rush into anything. You need to take your time and get it clear. But if it's more than 200, the top part, then that's serious. Something needs to be done. You do not need to wait you have to call the doctor at that time of high blood pressure of the top part more than 200 and the bottom part more than 120. The word we have for the bottom part is, the number we have for the bottom part is 90. If that is more than 120, you need to see a doctor. So 200, greater than 200 over 120 is an emergency. You need to be seen to that day, please. Now, people will talk about symptoms. They'll say, all right, I don't feel anything. So I'm well in myself. Most people are well because hypertension will not tell you anything until it's too late. By the time you're having symptoms, which is headaches, persistent serious headaches, that means your high blood pressure is really very, very high. We're talking of systolic blood pressure of like 180 and above. That's when you start having the symptoms. When you're about 160, 170, you probably feel nothing. So yes, so when you're having that headache is what to get your blood pressure checked. Or the diastole of 120. Yeah, next slide, please, Amy. Can we try the next one? Yeah, right. So when we classify high blood pressure, we've seen anything more than 140. So we have into mild, the moderate, and the severe. The one I just described now, which is about 200, 180, 200 systolic, the top part, 110, 120, the bottom part, that's severe hypertension that needs urgent attention, and that needs to be dealt with. There's no, you cannot wait. That needs to be addressed quickly. When you have the moderate, that is the borderline. You're now having the blood pressure between 160, 150, 170, that range. You can sit on that, but that still needs to be attended to. But it's not, so between 150 to 170, you're talking of moderately raised blood pressure. And then the milder one is between 140 to 150 blood pressure. So now 140 to 150, you could decide, we'll talk about the treatment later on. Now, majority of us with high blood pressure is usually in the 4th decade. Why it takes that time, we don't know. So there are many theories behind it that we do know that stress being the pathological basis of most illnesses, including cancer. A very stressed person, like this, where you're doing an exercise, you're on a treadmill, your blood pressure will be high. That's your physiological response to what you're doing. So when you're stressed, though it's not physical, mentally stressed, that could raise all the cortisols, all the chemicals in your body, and that could quicken your heart rate as well. And when your heart rate is quickened, your blood pressure will go up. They are quite a direct relationship to each other. The faster your heart rate, the higher your blood pressure if you're normal. And so stresses with all these cortisols and catecholamines, all those chemicals that really not good for our system, could raise your blood pressure. So that's very important. Yeah, I'm just right. So the what I'm talking about, the essential hypertension. We use the word essential hypertension. That's about 90 to 95% of people with high blood pressure. There is no reason. There is no main reason for it. It's just one of those things that we get. I'll tell people we're not designed to live here forever. We're here for a very short period of time as a human being. The body will expire. And one of the things that would expire the body are all these illnesses, diabetes, blood pressure, cancer. I'll tell people, wait till you live long enough. You will have to deal with these things because it's just the way the nature is, so that you would go, the next generation will come. So, but we have information now at our disposal that you do your health check, you pick up these things, you could manage them. Once you manage them, then you could probably prolong how long you stay here. So if you develop high blood pressure, why should I have it? It's not because of anything. It's because it's life. It's what happened. It's called essential hypertension. And what do you do? How do you manage it? Like I said, your lifestyle is very, very important. We've known that managing your stress level would really, really help you. If you're sleep deprived, you're not getting enough sleep, you're putting so much pressure on yourself, it will affect your health significantly. Things like that. So you can manage all those kind of things. If you're not exercising, you're overweight, that would affect your blood pressure readings because it has effects on all your organs, your body, your blood vessels. Once you squeeze your blood vessels are narrow, they are tight, the pressure for you to pump blood through them will need to be higher. So when you're putting that kind of pressure on your blood vessels, it raises the blood pressure and it causes problems. So yes, lifestyle, that by doing the right kind of exercises, keeping your weight under, the accepted BMI, which is your height and your weight level, body mass index, is very important, about 21 to 25. So if it depends on what your height is, your weight should go with your height, and that could be achieved by regular exercise, good diet, and try to keep to that as much as possible. Now, we talk about no symptoms when you are having high blood pressure, because it doesn't tell you symptoms, it's causing damage already. The example I use is when you try to wash your hand from a sink and you put the tap on, and the pressure coming out of the tap is so high that you even barely wash your hand. It's just high. It's splashing all over the place. You are not achieving anything. This is what happened with high blood pressure. The pressure in the pipes, they are so high, and what they are doing is causing some damage to the inside of the blood vessels. They are causing some damage to the end organs, to where those pipes are supplying. So if the examples of what we gave is your organs like the kidneys. So too much pressure to the kidneys will blow up the kidneys. So the brain will destroy the brain. It might be the back of the eyes and the heart. You can see the big organs there, and then the smaller ones like the retina and even the penis, the small blood vessels. When they go there, high blood pressure will destroy them. So we need to try and have a good control. Next slide, please, to show just some pictures. This is a good picture of the brain, what it looks like. That's a brain, a normal brain, pink, good convolutions and all that. But when people have high blood pressure, the blood vessels, tiny blood vessels to the brain, they are not supplying enough blood pressure because you've damaged those vessels. And what happens is you lose all these convolutions, all the nice pink colors, and that is what we call things like Alzheimer's disease, vascular dementia. Then there will be problem, damage to certain parts of the brain. Things like, and it could lead to a fatal attack like stroke, because if the vessels burst, or people just have a brain hemorrhage and things like that. So it's important that we control the blood pressure. The annoying thing, when you start doing all this damage, which is over time, you could do it over 10 years, depending on how high the blood pressure has been, and you've not had your health check to check your blood pressure to get it under control. The damage is already done. You cannot reverse it. So it's very, very crucial when you hit 40, anyone in this group must have a health check every year. Check your blood pressure at least once in 6 months, at least, just to make sure it's fine. Because it's fine, it was okay last year, doesn't mean it will be okay next, the bodies keep changing. So we need to be on top of our game. The next one, you will talk about the penis as well. The male erectile dysfunction kicks in mainly at about the age of 40, which coincides with high blood pressure as well. There is no bone in the penis. It's muscle, vessels, smooth muscles, and blood vessels. You need a good flow of blood to the penis to have an erection. And when you have a bad high blood pressure that has damaged those vessels, that's the problem. That's erectile dysfunction. And so you want to make sure that you control the blood pressure so that you don't have that kind of problem that could lead to a lot of issues. Next one is the retina, the back of the eye. I mean, like I said, those tiny blood vessels at the back of the eye, you could get really damaged as well, and that's blindness. People have, losing your sight would be not very pleasant thing for anyone because you probably lose your independence. Next one, please. The heart, very, very crucial. The heart is only one organ, very, very important. That's the engine block. That is where all the blood flows to everywhere. So when the blood vessels is high, like I said, it could lead to heart attack. It could lead to ischemic changes. We call angina. Angina is when you have slow damage to the heart muscles. That means you're not having enough blood supply that you're supposed to have. So the heart is not functioning optimally. When you push the heart, then you start having chest pain, central crushing chest pain. I use this opportunity to tell us about what angina is. The classical angina is chest pain. I've got pain in my chest, right the middle of the chest, not the sides, not on the left, not on the right the middle, and not the belly. It's right there up center of the chest, and it's like a central chest pain. That is the classical. Unfortunately, that doesn't happen in everybody. Some people do not have that. What they have is pressure. Somebody is sitting on top of my chest. When you feel that, please, it's an emergency. And the earlier you get help, the better. So you feel tightness, you feel like a belt right across the chest, or heaviness right across the chest. That's something that you should call 999. It's not even, I'm waiting to go and see the doctor tomorrow. You call 999, they will send a paramedics in. They will do an ECG right there at the spot. When the ECG says you're all clear, fine. So please do not postpone such things. Anyone with that kind of central heaviness, crushing pain should call 999, please. Next one. So the kidney, very, very important organ that filters all the toxins in the body. It's also responsible for the control of blood pressure as well. Yes, the kidney needs to be protected. And when there is uncontrolled high blood pressure, it packs up the kidney. And when kidney fail, there is no health. Health is gone. So it's important we have a good control of blood pressure. Thank you. Now, we talk about treating blood pressure. We've already spoken about lifestyle changes, by managing your stress level, paying attention to your diet. Any diet high in salt content is not good for blood pressure. A high salt content would lead to high blood pressure. So if you could minimize our salt intake to a very low salt diet, that would be very helpful. So we wouldn't oversize the need to do exercise here. It's very, very important that we're active, keep as active as possible. In fact, it's been proven that all these little changes could stop you from even needing to go on tablets for a very, very long time. Blood pressure is very smart. You are doing something to control it. It's trying to beat you. So after a while, you might need to take some tablets at some point when they are not well controlled. So despite all your exercises, the blood pressure is still going up and everything. You have to continue exercise anyway, because if you're not doing it, the medication has an effect to how far it could go. You can't just sit down and say, all right, take tablets, then it control my blood pressure. It won't work. So you still need the exercise, then plus medications. Unfortunately, the medications studies were done on this part of the world were on Caucasians, the medicine that works for them. They are the majority, we are minority. So you'll be on all these Caucasian drugs that will not work for you. So please, it's important you have the information. The classification of blood, the treatment, they use the word ACD. It used to be A, B, C, D. A, B, C, D used to work for Black people, but the B doesn't work for the white people, and they've taken it out. That you don't use it for blood pressure anymore. We do not use it anymore in this country. In fact, they've taken it out of the NICE guidelines. The B is the beta blocker, which is the whole, when we say atenolol and all those things, they work for us, but it doesn't work for them, and they've thrown it away. So the A is they're called angiotensin, the ACE inhibitors, angiotensin. Angiotensin is a Latin word for angio is blood vessels, tension in the blood vessels. So angiotensin receptor blockers. Those are the ACE. There are a group of drugs there. The A is their own first line of drug that they use to control them. But it doesn't work for us. It doesn't work for Black people. We are the pathology, just to keep it simple. I think it's the genetic, what we've been over time, the evolution. We've lived in a very, the environment we lived in, we're already having angiotensin in our system, in our kidney, is already there. So when you use the drug, you are just taking tablets. It's not, and most people will be on it and be wondering why it's not working. It doesn't. We can probably address that another way. I'll try and see if I have time when we talk about diabetes and talk more about it, because it's a very important drug though, but in controlling the Black people blood pressure, no, it's not doing anything. So the next one is calcium channel blocker. That's the order. When people present to you with high blood pressure in the clinic, you diagnose that, you give them ACE inhibitor first. And it's not working for our home people. Like I said, that's not the first drug you should give for our own people. You give them C, which is calcium channel blocker. Calcium channel blockers are the common one, which called the amlodipine, nifedipine, the usually just Adalat and all those. Those are the ones that work for us. You put somebody on it, boom, the blood pressure will crash. And so I really encourage you, if you're on ACE, make sure you're on calcium channel blocker as well. It's very, very important. And then the next one is diuretics. The diuretics are the, we call them water tablets. You know, when you take them, your kidney, perfuse your kidney. Once your kidney is You were peeing, your blood pressure comes down, it controls everything. You lose the volume, the intravascular volume. So when you reduce the volume, it lowers your blood pressure. So those are the direct. So the classical thing is A plus A, C, D. Now, for us, like I said, I promote C. It should be C plus A, D, rather than the way they've put it there. So it's important we hold this information and pass it around to people as well. That's where you go on medications, but I'm not an advocate of medication. It's a last resort when everything else fails. And please, they are okay. If you're not tolerating, you start one pill, it doesn't agree with you, go and see your doctors, get on the next one. There are so many drugs that could help. And one of the most common side effects why people drop it is when they take a tablet and it's affecting their erectile function, because most of the blood pressure pills, they cause erectile impotence. You know, that's what the horrible side effect, but not all of them are doing that. So when that's happening, you speak to your doctor, they'll find the right one that shouldn't do that to you. Thank you. Now, like I said, we want to talk about diabetes. You cannot talk about hypertension and not talk about diabetes. It's just two terrible illnesses. Diabetes is when there is sugar in the wrong places. Not that they check your blood sugar and they say, oh, you have high sugar, so much high sugar. You start wondering why. So the sugar should be inside the cells. They should be in the where they're supposed to use. The cell uses sugar. The cells uses sugar, because that's where all the activities, the energy, everything that we need is supposed to happen. So, but when you have the sugar outside the cell, they are extra, they're not in the where they're supposed to be. That causes problem. So that's why they use the word starvation in the mix of plenty. You've got a lot of sugar, but they're not in the right places. And that's diabetes. And diabetes is so important that it costs the NHS so much money, especially the complications of diabetes. Managing diabetes is cheaper than the complication itself. The complication we're talking about is amputations. People losing their limbs because from diabetes they have ischemic legs and they have amputation and all those things are. Thank goodness is getting better now because we are aggressively managing diabetes, so we're not having that kind of horrible presentation. The time we did this slide is very funny. This probably was pre-COVID, 5% of the population with diabetes. I can tell you categorically we have about 7-8% of people with diabetes. It's going so high. In some area, especially the deprived area, you have as high as 12% of people living there with diabetes. When you stay among the ethnic minority, the low social income group, you can have as much as 15 to 20% of people with diabetes. And they're just walking the street. They're not even doing checkups. All you need to do is go to this eye street, start checking everybody's blood level, and you find out they are even diabetes without them knowing, because it's a silent killer as well. It doesn't tell you anything until it is too late. Yeah, and there are two types of diabetes. The one that affects us mostly here is the type 2. Type 2 diabetes is non-insulin dependent. The type 1, which we use, is the insulin dependent. That's the one that presents in childhood. The organ responsible for controlling sugar is the pancreas. The pancreas sits right middle of between the upper part of our tummy and the lower part of our chest, right behind the pancreas. So that's where we secrete insulin. Once you have sugar level, high sugar level, the insulin will stimulate, will come out, mop up the excess sugar and control it. It does that very well. But as we get older, the body mass starts increasing. When the body mass starts increasing, you are putting so much pressure on the insulin. The insulin cannot match up with your body weight anymore. It's struggling. Whatever is pumping, your body is just too much for it. And this is one of the main reasons why obesity is one of the main cause of type 2 diabetes. And obesity can be related mostly, not 100% of cases, to our lifestyle choices. Sweet tooth, lovely carbs, too much carbs and all those things will lead to high body, sedentary lifestyle would cause problems, with our weight. And that inadvertently leads to type 2 diabetes, which is a horrible, horrible disease to have. But it can be avoided. It's avoidable in most cases with lifestyle changes. Next slide, please. Now, so to diagnose diabetes, that will involve you either going to the doctors, really. You need to do a fasting blood sugar. That means from like 10 p.m. till by the time you have the test next day, you can only have water, no food. just have the test done. They do it, like say 12 hours fasting is the best. If you could do 10 to 12 hours of fasting and they do your blood sugar and it's less than 6.1 millimole that you need to put there, then you're not diabetes, that your fasting blood sugar is fine. But if your sugar is more than 6.1, you are diabetic. So there is no two ways to it. There are no two ways to it. Now, there is another test that's been introduced because that's a sport. It could be a transient thing. You could have high sugar, which we call impaired fasting glucose, during illnesses, acute illnesses. People have come up with viral illnesses and their sugar is just crazy at that time. That's a transient high sugar level. So we call that impaired fasting sugar, which could probably revert to normal. So you can, okay, I've done a blood test. This person is 6.1. Instead of me to label them as being diabetic based on that result, we don't do that anymore because we now have what we call glycosylated hemoglobin. That means the hemoglobin is the red cells that circulate in our body, the blood. And this hemoglobin lives for about 120 days. That's their lifespan. Every red cells you produce from your bone marrow. They could probably live up to about 120 days. So that hemoglobin carry some sugar, the amount of sugar in your body. So it's been carrying it for almost 120 or 120 days. So we use the word glycosylated hemoglobin. So it could give you an average of your sugar in the last 3 months. So you could have accurate reading of what's been happening in the last 3 months. So when we do that and it's more than 48, that's diabetes. No two ways about it. If it comes back at 48 and above, that person is diabetic. Now, there is a range that we should talk about here, which majority of people will probably fall into. I would be surprised if not half of these people here fall into that, including myself. It's the range between 42 and 47 is called pre-diabetic range. That wasn't important when we had this talk a few years ago. Now that we're having it, is very, very important. Pre-diabetes is a marker that if you do not do something, you will become diabetic in the next few years, maximum 5 years. So if you fall between 42 and 47, let's say your level come back 43. When you check it, you want to know what your HbA1c is. If it's 43, 44, that's a pre-diabetes. You have to treat yourself like as if you're diabetic. The only thing you don't do is be on tablet. So how do you treat yourself? You have to get the weight down. You need to reduce your calorie intake. The cure for diabetes, anyone, is 800 calorie. Who lives on that? 800 calorie of food in carbs daily. So it's like starvation. If you can live on 800 calorie of carbs daily, then you will not have diabetes. It's cured. But that would be serious wahala for a lot of people. So we can do all the other things. So please keep your HbA1c down. If you get the level done every year and just follow the trend. So we've talked about the complications of hypertension earlier on. Not to repeat everything. The same thing hypertension does, diabetes doing the same thing. It affects the brain, it affects the heart, it affects the kidney, it affects the, in fact, this guy is a bad one for erectile dysfunction. Anyone with diabetes, that's a very important question the doctors will ask them. How is your sex life? Very, very, because diabetes is toxic to the penis straight away. And even the NHS is right, give them Viagra. They need to be on Viagra. Please, there's nothing wrong with having Viagra. In fact, I have to emphasize that. Take it. What it does is to promote blood flow to the penis. And if you're not taking it, the blood is not flowing there, and you now lead to what we call disuse atrophy. You are not using it, and the blood is not flowing there. You're not having the early morning stiffness. It's a matter of time before the penis will realize I'm not needed here, and it starts shrinking, and it just starts going. So when you are diabetic, use your sildenafil or Cialis, whatever one they provide. Use them, maybe not every week, maybe every other week if you don't, because ideally they ask you to use it every week. It's very, very important to make sure things are going on in the right directions. So like I said, it's all the same complication as in hypertension. Is that the end of the slide? Is there anything else after this? Okay, management. Okay, so we talk about the management of diabetes as well. Now, when it comes to managing diabetes, the commonest thing for the one that affects this group, we talk about the type 1, which is lack of insulin. If you don't have insulin, you need to replace them with insulin. That usually affects the younger age group. But for this group, it's more of tablets. And there are many, many other tablets. The first one we put there are the sulfonylureas, all those ones before, forget them, throw them in the garbage. We've stopped using them now, within 2 years now. So we do give it to some people who have very, very bad diabetes. The guy we put number 2, metformin, is the first line of treatment that we use for to treat diabetes now. The sulfonylureas, they're still in use, but we leave it, like I said, is for a very, very bad diabetes that will not listen to metformin. What does metformin do? Metformin improve the movement of sugar from the extracellular space into the intracellular space. It promotes that entry. In fact, you can use metformin not just for diabetes, for other things as well. But we found out that shift of movement from the extracellular to the intracellular, where the sugar is needed to do combustions, to do metabolism, to stimulate metabolic activities, is what metformin does properly. And in that process, it helps with weight, reduction of weight, and improves diabetes. Now, the modern drugs that we've brought out now, which is fantastic and good for the Black people as well, is we call them SGLT2. This tablet works on the kidney. What does it do? It promotes you to pee out the sugar in your blood. You just pee out. All the urine you are peeing is sugar. Loads of sugar coming out of your system. You're losing them. So that's how this tablet was. Fantastic. It's very expensive. It's very modern. It's very new. Probably less than 5 years now. But it's a drug you want to be on, especially if you're overweight, if you have a very bad diabetes. So the example of those SGLT2 is the receptor is the SGLT2. We just call it SGLT2. So the example we call them canagliflozin. Anything finishing with zosine. So empagliflozin, dapagliflozin. So those are the examples of the drugs in that group: cana, empa, dapa. Now, doctors will say, all right, I'm not prescribing this drug. It costs, each tablet costs over £1 that you take every day. Please ensure you're on it. You know, it's your health, it's important. Just say, why am I not on this tablet? Some people still do cost measure, but we shouldn't do that with diabetes, because like I said, the complication of diabetes alone is costing the NHS 10% of its budget. And that is, if I'm correct, as of 3 years ago, we're talking about over 20 billion. Yes, over 20 billion pounds that is costing the NHS to manage complications of diabetes. So they want to do everything to stop spending that kind of money. So whatever a pound you spend today is saving you 20 billion in future. Part of that, they will rather do that. So if you're SGLT2, it's something I would really advocate that please get yourself on it if your diabetes is not well controlled. And then we have other drugs too, like the DPP4. They work on the pancreas. They help the pancreas, to behave itself, and the liver. So that's where they work, the liver and the pancreas. The liver is the engine box. It's where you filter rubbish, junk, and everything. It's just like how do I call it? Recycler. That's what the liver does. So this SDPP4 works to that area. They are usually once a week injection. They are not insulin, but they're injectables. Very, very good, effective. You inject it once a week, and that's it. Some people, that's all they are taking. They inject it. So it's not insulin, like I said. It helps the weight to come down, and it controls diabetes excellent way. Example is what we call Byetta, Trulicity, in that group of drugs. So, and like I said, there are other drugs as well. The gliptins, the gliptins are another sort of drugs that helps to this work the same way as the DPP4. They work in the same way the liver. That's where the gliptins work. And the example is called sitagliptins, linagliptins, and all those things. So now, to manage diabetes will not let you manage it. It will try and stop you from doing that. It will fight you all fronts. Like I said, it's an existential issue here. You want to stay as long as possible, healthy, good life for as long as possible. The life is saying, no, you are not going to do that. So it's a battle. So it will weigh you down psychologically. So you have a chronic illness, because they are chronic illnesses, chronic disease, diabetes, hypertension, they're not going, you're not curing them. They'll be with you for life. You can get really fed up. After a while, I'm tired of all these things, I give up. That's the disease beating you psychologically. So you have to make sure that doesn't happen. It's not going to beat you. So you have that information that, look, you are not going, I'm not going to leave you alone. So, you fight them heads on. So make sure it's part of the management to make sure you are psychologically in tune to fight the disease. Now, whatever tablets you're throwing at this disease is fighting you back. It's trying to outsmart you. So you're throwing something, he's doing the other thing as well. So when you are taking metformin, you say, I've not changed my lifestyle. I'm doing everything by the book. Why is it? That's what he's trying to do. So what do? You bring another agent in quickly. That's why you do your regular follow-up. So when you take metformin, you're taking linagliptin, you're taking everything. What are you? You are approaching the disease from all angles. You are hitting the liver. Whatever is happening in the liver, the gliptins, the DPP4, they're taking care of it there. At the cellular level, you are using your metformin. At the muscular level, at the pancreas level, you are everywhere. You are covered all angles that this thing is going to come from. That is the approach. It's a multi-approach from every angle. You cannot just say one approach. So yes, I think psychologically, when you are like, I wasn't taking anything before, nothing happened. Why is this happening to me? That's nonsense. You live long enough, you'll be on pills. You'll be very lucky not to be on pills. So we need to, forget that, because I've seen people, no, I'm not going to take pills. I'm going to do this, I'm going to do that. Nobody, please, don't do that to yourself. When you need these things, take them.
Thank you. Thank you very, very much, Dr. Fatai. Really, really appreciate it. I'll now stop the recording and